ngiphinde nginamukele kwezempilo zami uDakalo na Dr. Crew. Namhlanje sibuka udaba olubaluleke kakhulu lapho sikhuluma khona ngobukhulu ngomtimba lokho sithi phecelezi iobesity. Kanti angihambi ngedwa, kunodokotela wethu esimlanda le eGqeberha ozosi-introduce ukuthi ubani igama lakhe kanti kanjalo nezinye ihambeli zethu la ku-studio. Singaqala ngawe lapho Dr. Nonjogo.
Yebo, manibulise kuwe, nibulise nabaphulaphulalaleli bakho. Igama ngulungisa Nonjogo, as you have said, ngisuka eGqeberha, original from Transkei. We started here as a Center for Integrative Medicine. We've been running now for more than 10 years. Apho senza khona services eziquka research, clinical trials with special interest on obesity, and in mentorship programs looking at clinical economics, integrating health and economics and sciences.
Sibonge dokotela, size ngawe sis Abigail ongachazela ababukeli emakhaya ukuthi ngubani?
Ngiyabonga, nalanga ndi Abigail Mbekwa, ndi qualified biokineticist, ndikweshumela wellness company. Renata the biokineticist, reshuma utandabuza mubili, and then reshuma na promoter health and wellness, kaba tubote, auteyu ulwala uri promoter health and wellness, repota mwana mumwe, and then retirana nga the sport injuries, and then manager the chronic conditions, zabatu wanibokulwala.
Sibonge kakhulu sis Abigail. Dr. Noviwe?
Ndiyabulela sis Prudence. Ndiyabulisa kuni babukeli ndingu Dr. Viwe Nokaka. Originally from East London, Eastern Cape, I'm currently working Tata as a plastic and reconstruction surgeon. I deal a lot with people who need to lose weight for certain procedures to be done. So that's my special interest is in also in weight loss.
Kanti Dr. Viwe njengoba usithi uyi-plastic surgeon. Yini kahle i-plastic surgery kanti futhi uma ufuna ukuspecialize ngayi-plastic surgery ithatha isikhathi esingakanani?
Plastic surgery is a specialty where we deal with I'll frankly say a GP of a general practitioner of surgeons. We actually do anything that any surgeon is failing to do. We fit into reconstructing. We're trying to put your body into reasonable normal position post ingxaki obunazo. Can be accident, it can be ukhuluphala, unwanted ukhuluphala, it can be uzalwe ungekho une deformities. So we try to fix all those problems that abantu abanazo as surgeons. We good. We have good in research. We come with principles of how to deal with different problems zabantu to bring back bayoba more normal than they are post ingxaki. It's a good specialty where you study medicine, MPCHB, when the internship like any other doctor and community service. After that, we spend about 18 months, at least 18 months, with different specialty being your cardiothoracic surgery, your general surgery, your pediatric surgery, with all different specialties, because you need to understand how they deal with their problems. And then after that, you have to spend at least 4 years then studying as a plastic surgeon. So as much as we say but it's so fulfilling, it's so beautiful, and I will say it's one of jobs as the most satisfying. I've never had so many NCOSs in my life after I've done procedures. So we literally, other doctors, they will say they save lives. But we restore quality of life.
Nibuyisela lokhu uNkulunkulu umuntu amdale ngakho ukuthi
Yebo.
abombe ngakhona.
Yebo.
Bonkulunkulu bethu basemhlabeni lapha. Sis Vicky?
Okay, hello, students and everyone. My name is Vicky Munyamane. I'm a clinical dietitian. I did a specialty in obesity management and bariatric surgery with the University of South Wales. I also spent years investing in learning a lot about diabetes management, and I'm certified to be a diabetes educator. So my field of interest is a lot to do with metabolic diseases and nutrition, how nutrition contributes to causing chronic lifetime diseases, and how in the same manner nutrition can also be used in restorative health. So I love what my colleague Dr. Nogabeta said, that we restore quality of life. As a clinical dietitian, my place is to ensure that my patient living with a chronic illness does not spend time in a diseased state, but actually can return to life and function and lead a very productive life, whatever chronic illness the patient has, whether it's chronic pains coming from arthritis and things of that nature. So as a clinical dietitian, we pay attention a lot to the metabolism of cells and really trying to give the patient back what life can look like, even if they're living with a chronic disease. So alongside managing patients with doctors, you want a patient to retain a state of wellness where the patient, even if they're conscious of the fact that they do have a chronic disease, but they can actually be healthy, and that meaning they're not in a disease state, they're functional, they're feeling well, and they're active and managing their disease very well. And it's about ensuring that whilst the patient is alive, they're not dead whilst they're alive. They're very much functional and all that. So that's what I do.
So ichaze kabanzi nokuthi kungani kahle hle uthanda ukuba i-dietitian, kanti besingazi futhi ukuthi kanti niyake niqhubeke nifundele ni-specialize nangobo bariatric, ni-specialize nangama-obesity. So sisho ukuthi sisihleli no-dietitian alright lana ozosithatha sibeke njengoba sizobe sidingida idaba le-obesity. Dr. Mahlangu.
Thank you very much, Dr. Peru. My name is Dr. Mahlangu, Reshi Mahlangu. I am a qualified GP, and I am the Senior Manager Medical Advisor for GEMS, which is the second largest scheme in South Africa and the largest closed scheme in the country. Also, full name is the Government Employees Medical Scheme. So we cover about just over 2.01 million beneficiaries, and we have some of the widest reach in terms of the members that we have. We have given access to healthcare to those who were previously uninsured, and it was unaffordable for many members. What we've done is we've actively promoted the scheme to, as government will call them, levels 1 to 5s, who have previously had no access to healthcare. And one of the things we do consider is to constantly review how we give better access to healthcare and how we improve the benefits that we give to members. We've got a wide reach of members who aren't even mainly in urban areas. They tend to be in rural and peri-urban areas, so that everybody can have access to healthcare. Thank you.
Thank you so much, Dr. Mahlangu. Dr. Lungisa, njengomunye wabodokotela oseqale ikliniki ye-obesity lapho eGqeberha, ungabe uchaze nje ukuthi kungani uqalile ikliniki ye-obesity kanti usunceda abantu abangakanani nge-obesity?
Okay, because we run wellness clinics, we've got about 6 clinics that we're running integratively in the facility. And one of our biggest clinics is Clinic Yabantu Aba Pila Nesifo Seswekile. And as you would know, about 70 to 80% of those people have got a problem of overweight and or obesity, especially type 2 diabetes. And then CSATike South Maskuti ingxaki le problem ye-obesity or umzimba, umphilo nomzimba omkhulu. Sabese ukuthi sihlangane with one of the research institutions, international research institutions and companies ezinobuchwepheshe kwindaba ye-research obesity. And then we started now to set up a clinic as of focus on obesity as a add-on clinic here to diabetes plus cardiovascular clinic, which we run on site. And that clinic is I think about 12 months ago, with the support of Novo. They provided us with equipment. Because most setup at the facility, you need to have the right scale, the right sitting arrangement, the right environment. And then with us, we had the space and also had the teams. We had our diabetic nurse, which was trained on obesity as well. And then we also have got in-house dietitian that was also orientated and trained on obesity. And we also have got in-house psychologists that we're using for other clinics like HIV clinic that also had to be brought in to manage depression, anxiety, and some other issues that actually affect the behavior, the eating patterns about that are obese. And we're also very fortunate because not far from us, we have a facility that has got a bariatric surgery center that we refer patients to, those patients that actually are eligible for bariatric surgery. We started this clinic about 12 months ago. We've got about 30 patients now on the system, and we manage our patients in a sort of patient-centered approach, where we actually make sure that we listen to the patient and the patient becomes an active participant in the program. And also we provide systems for support after a thorough risk assessment that is checking what is the main cause that is driving obesity in the patient, and what are the complications of obesity, and what are the barriers that may affect the program, and then what are the response, and how can the person become part of a solution, and we set up the support systems for the patient. It has worked, but there are challenges because it's a fairly new area really. In the past, I think all of us with the and really we've been marginalizing and actually stigmatizing to an extent that abantu that were either living with obesity, they were actually very lost, big peripheral health systems and also good communities at large. So in a way, we learned a lot from the science behind it, and we passed the knowledge to the patients and the support systems. And I can say now at the moment, those patients that are in our system, we learned a lot in terms of what works and what are the challenges. And we're actually applying that to patients that we're recruiting so that we deploy tools and also research methods so that it's evidence-based approach in terms of our interventions to patients. We have patients that have actually regained their quality of life, because I think what we discovered kuma patient among is abantu abaningi they didn't understand obesity. That is both from doctors as well from patient perspective. And once we sit down with patients, I understand it's not their fault, then they become active participants, and then they can actually play a meaningful role in actually driving and modifying their lives. But I must say it's a team-based approach with the patient in the center, because without the patient, there's no program. Without the patient support system, there's also no program. That's what we've learned. Yes, I think we're very fortunate because when we started the program, it coincided with the launch the tools that could be deployed in addition to other interventions. That is, I'm talking about medicines now that we registered for obesity, as well as obesity in diabetic patients. So we're using those in addition to other resources that are put around the patient. And I must say, we're beginning to find successes, and we begin to get patients that are very satisfied and that are actually beginning to see obesity as a chronic disease process, and not necessarily as a weight loss thing, but also that are beginning to see that it's a lifelong, long-term program, just like diabetes, such as HIV. And we managed to pull in the support system and educate those families, because without them, the patients tend to be isolated and they tend to be fatigued and by is too big.
Manje dokotela njengoba sibuka umhlaba wonke jikelele ngabe bangakanani abantu abaphila ne-diabetes ne-obesity masibuka nje epidemiology?
Well, if you look at obesity, it has been there for quite some time, but even money, the attention that I think it should, it deserves. If you look globally, you look at about 650 million people that are living with obesity, and that number is projected to be about 1 billion by the end of 2030. But then, if you look at Africa, I'm talking about adolescents as obesity. We're looking at about 150 million, and that's a huge number. And then if you drill down, in terms of isini, abantu abaphila no-obesity, that is females less than 20, so looking at about 26%, and then abang that are living with obesity, adolescents, looking at about 19%. Now, because we've got quite a number of people. If you look at the overall population, it's about 26% of adults that are living with obesity. But the majority of them are females that are, I think, about 41% that are obese, and with about 23% are with overweight. And then most of them is about 11% are with obesity, and then about 23% that are living with overweight. So, in obesity, and actually should be supposed to be saying we've got another major pandemic, and we need to have a very strong public health approach, and also very strong systems and tools and collaboration among stakeholders to ensure that this disease, because now it is a disease at the end of the day, that's how it's supposed to be managed. So it's supposed to manage a chronic disease, and not as an acute thing like lose weight just because that's not the way to do it. It's supposed to be approached from the angle of a chronic disease, and also need to make the point that abantu don't feel stigmatized. And it's not as simple as a question of eat less and move more anymore. We know the pathology now, we know the pathophysiology, we know the causes of obesity, we know where the centers that are actually driving obesity are situated. So it's supposed to be a question of normalizing the physiology. That is how we're supposed to be actually approaching obesity at the moment.
Obesity ifana nama-chronic disease iyafana noshukela high blood pressure, but uma unesifo seshukela siyazi ukuthi kwenzeka lapha ku-pancreas khona izinto ezi-abnormal. Uma kuyi-high blood kusenhliziyweni, uma sikhuluma nge-obesity isiphi isitho somtimba kahle hle esi-affected?
Yeah, it has just been recently discovered ukuthi the brain, that is ingqondo, especially within the brain, the subcortical areas that isn't are the one that actually driving obesity. Because in certain areas of the brain, hypothalamus and nesine areas, you've got centers there that control satiety and hunger. Just like any other condition or disease, obesity has got symptoms, obesity has got signs, and obesity has got complications. Now the symptoms of obesity is excessive hunger, unstoppable, and then plus also add any with satiety that is considered. And when you look into the brain, you'll see that in the hypothalamus, you've got centers that control these areas. Not only that, there must be a healthy communication between these areas of the brain plus other parts of the, especially other parts of the brain plus the GIT. Now, kubantu that are living with obesity, there's a problem, there's a blended communication between the gut and other peripheral tissues and the brain. And this is the reason why, if there's no good feedback from these areas, then the brain cannot reach that the person's, and then you start to have dysregulation between satiety and also hunger. So it's quite a complex pathology or mechanism that leads to obesity, and it has got to do with physiology and a little bit of evolution, because you would understand that in the past, and the brain was wired in such a way that you need to conserve energy so that in the process of going hungry, you've got enough energy stores to keep you going. Then what happened? Fast forward that to 22, you've got fast food outlets, which has got everything. So but then at the same time, you're actually storing, the brain is actually been wired for you to store kuja. So what happens? You become bigger, and there's some other areas and other dynamics that make you get fatter. But that's got to do with the brain having been wired to actually defend weight loss, to actually assist you in storing energy, so that in the event that you go hungry, you can actually reuse those reserves. But at the same time, you've got dysregulation between those centers of the brain and poor communication between the gut and the brain and some other peripheral tissues that are supposed to be in harmony with how the brain functions, so that at all times there's a good balance between hunger and satiety, so that you don't have to eat unnecessarily. You eat only to get full, and your body should be able to say, not about I'm craving. Understand? So you've got other centers that are playing a big role to obesity, like reward systems, and also poor communication of the prefrontal cortex, that is other areas of the brain, that we call them executive, that control the executive function of the brain. And that has to do with obesity as well. But the main culprit in obesity is the subcortical areas. In other words, it tells you then that it's not within your control. So then how do you tell somebody eat less? The obesity is controlled by the subcortical areas of the brain. So the main thing is the physiology that must be restored.
Dr. Mahlangu, as you are taking care of many communities out there as James Medical Aid, I believe that there are many of them who are living with obesity. How do you see it? And as the doctor is saying, this is a pandemic. People outside there, they only know pandemic, COVID-19. Pandemic, we talk about COVID. We've never thought that obesity is a pandemic. What do you say about that?
So, because it's a non-communicable disease, it sort of doesn't register to people that this is an actual pandemic. So when people hear the word pandemic, they think it's a virus, they think it's some type of, disease that you can pass from one person to another person, without realizing that even non-communicable diseases, or what they previously also known as lifestyle diseases, is a pandemic. We have so many people in society who are diagnosed with diabetes, so many with high blood pressure, so many with high cholesterol, and they don't see that this is also what qualifies as a pandemic. And I think once we get that mind shift and the education gets out there, then people will also realize that obesity in itself is to a pandemic.
Is that the reason maybe that led to obesity to be one of the prescribed minimum benefit conditions?
So the prescribed minimum benefits is actually a very historical intervention that was brought into the medical aid environment. I mean, this goes back more than 20 years. And it was based on the fact that at the time, medical aids could decide what they're covering and what they're not covering, and especially not covering what they call catastrophic events. Like if someone is diagnosed with cancer, the medical aid would be like, no, this is too expensive, we're not covering. So then it was decided at that time, with the Council of Medical Schemes and other players involved, to introduce prescribed minimum benefits that forces the medical aids that this is the minimum conditions you must pay for. And during that time, they also said, what is done in state must obviously be paid for in your medical aid. That is the bare minimum. And what's been happening within industry is that legislation is not keeping up with the reality of what medicine is. Along the way, certain interventions were introduced to try and assist, but there's still a lag and a disconnect between the chronic condition of obesity that my colleague has spoken so eloquently about and how medical aids still see it. So there isn't that shift. We still see it in silos as the high blood pressure, as the diabetes and the cholesterol, as the heart attacks and the strokes and such conditions.
Kanti Dr. Lapokai, what exactly causes obesity? Can it be hereditary? It's in the gene. Usicela usithethe nje usibeke ngama-causes we-obesity.
Yeah, among causes of obesity could be anything from genetics to epigenetics, the environment, and also the neurobehavioral changes. Because you know, but sometimes, and other causes are iatrogenic because we put the patients on antidepressants, for instance, and certain patients have got side effects of obesity. But genetics play a very important role in actually driving obesity pandemic. But the real culprit really is poor communication between your subcortical areas and your peripheral tissues, and the real culprit is hypothalamus, which has just been discovered recently, which has actually now started to drive the set of new research interventions in obesity management. It's not a question of eat less and move more. It has just been discovered, but now it's a problem of physiology with the hypothalamus, that is the area in the brain, in the subcortical areas, that has been found to be wanting with regards to normal management of energy regulation or energy balance. Yeah, ezinye izinto ke zenziwa zizigulo esinazo obufanele ukuthi abanye abantu bane-problem, especially mental health, which can either be due to an after effect of obesity or the drive of obesity itself. Because when they're depressed, abanye abantu they eat more, abanye they eat less. But the main culprit really is subcortical areas of the brain, which is the hypothalamus, and nezinye environmental stimuli, including exposure to fast foods, especially highly refined foods that we eat a lot these days. Obviously, with the question of lack of exercise, obviously, and the question of is in a environment. But the main culprit is the hypothalamus and the abnormal physiology. That is a communication between the central parts of the brain as well as the peripheral aspects of the brain, which is what the interventions as Sandu discovered from Manje are trying to address. You're looking at especially the guts, isisu, amatumbu, the pancreas, the liver, the muscles, and the fat tissue. Those organs play a very important role in communicating the energy stores and energy reserve to the brain by producing certain hormones and also communication tools to the brain to say, no, that's enough, don't eat, I've got enough stores, or eat, I'm hungry. But the minute there's a dysregulation or imbalance, for whatever reason, between those peripheral tissues and the neuronal circuits or hormonal circuits that are supposed to link to the brain, and the brain itself, then you're going to have a problem of actually having too much energy. Well, of course, you need to address other epigenetic factors, environmental factors. So that's why obesity cannot be managed by one specialty. It has got to be managed by a team of specialties, including your dietitians, biokinetics, and also environmentalists, endocrinologists, and then also your bariatric surgeons, plastic surgeons. Because at the end of the day, it's about quality of life. It's not about weight loss. You need to ensure that you restore the quality of life, because you want to make sure that the person focuses on the health outcomes that are linked with obesity as a disease and not necessarily the numbers on the scale. Because we tend to focus people on the numbers of the scales, and to the extent that they get so frustrated when they can't get those numbers. And yet the science tells us a minimum 5 to 15% of body weight loss that you can sustain, it gives a health benefit. We should focus our patients towards a health benefit, not necessarily just weight loss, when we talk about obesity as a chronic disease.
Afiki, but to go high bana do nagana hore motho o obese ke hore o ja thata. That's the only reason, but at least Dr. Mola, what obesity, where does it come from? What are the causes? Maybe.
As Dr. Afetaho, obesity itself in a multi-cause, in a multi-factors that causes obesity. if we're talking about food, then we're looking at we'll cluster food in the environment. So it's part of what you call the obesogenic environment. So you find that yes, a person could be born with obese genes, but they will need a suitable environment to express. Now, when you're looking at food, a person is not necessarily obese in silo. The person comes from a family, that comes from a community, that comes from a village and a society. And all these things influence how we get to eat. So when we're just looking at food, the way we eat, it is a reflection of that environment. So if now, for instance, you come from a village in Emalahleni, somewhere in Mpumalanga, the kind of diet that would be consumed in the environment would be a certain way. But you find that the society perceives that as you go up the economic ladder, you need to eat a certain way. So, and that's what actually changes a lot. So you'll find that within a certain income bracket, the food changed to a certain type of food. But so previously, people were changing their diets as they increased their income to accommodate more what they see advertised. And they start to eat a lot more obesogenic food. But then now you find that, as he said, that statistics are such that South Africa is sitting in the top 5 of the obese countries in the whole world. We are about number 3 in the whole world. So, and you find that even in the cross and in the poor regions of the country, the diets in the poor regions are also becoming obesogenic. The diet in the middle class are obesogenic. The diet in the higher ranges now, in the higher economic ranges now, are much more healthier. And these are like designed by some forces that people with a lot of money are able to protect themselves when the poor cannot protect themselves. So if you're just thinking the food and the perceptions in the past that if you are rich, you are supposed to eat a certain way, have umkaba that says that you are wealthy. So food used to speak louder than what went to the stomach, because what you ate used to signify your social standing in life. And you find that the social standing financially continues to be a discriminating factor a lot. And we've seen it COVID. The poor died a lot because they're eating very inflammatory foods, becoming more obese, and they're the ones that took the strain. The rich could protect themselves with what they ate, and they could also treat themselves a lot with their nutrition. They could afford to buy the zincs, the seleniums, and even the food and the diet that can provide. In fact, they even had access to that knowledge. The middle and the poor, on the other hand, continue to eat obesogenic foods, and they're the ones that perished more with COVID. So then there is just that stigma that if you see someone that is larger than everybody, must be careless of their lives, must be eating larger than everybody else. So it does actually not even pay attention to why that particular person is obese. So there's just a complex of reasons why a particular child at school is larger than everybody. The child could be coming from a family that believed that now that they have went up the ladder, they could afford to eat A, B, C, D, E, and as they got more money, they started to eat more different. And so we find a lot in South Africa, like the new money effect, even in terms of the food you see it on food, and the new behavior that comes with new money, and also the lack of money effect that limits your access to food. So the old stereotype that when somebody is large, therefore they eat like a glutton, it's something that also has put the stigma to people that are larger, and also has discriminated. So you find that even the images of beauty also became an issue, like to stigmatize people that are larger. And it just created a complex of, are you obese because you eat a lot? Are you obese because you have money? Are you even obese because you are, because you are larger than the next person you see? And it's just all those kind of things that actually become a bit of a problem in terms of stigma.
Usabuwa ka stigma. Guys, una le stigma, even libana is Dr. Buletore, una libana baba kulang ba obese, and then ukra urba tizi wa koskolong, even go merogong, inkabi this thing, ukabita ure, pira halang pila ubaning uba lead stigma.
You know, the stigma of obesity comes generations past. You know that someone that is a sloth and a glutton. And then, of course, the social images of what beauty is. So a person that is larger is often stigmatized for being a sloth. So that means you must be eating and lazy. And a person who's obese would be stigmatized for being a glutton. So it means you just graze through food without consideration, without any. And then, of course, the social image stigma that comes from, I mean, these are like bureaucratic stigmas that come from along. If you're royal, you eat with poise or you eat a certain type of way. And if you are beauty, and also the standards of what beauty is and what beauty is not. So the stigmatization of obesity it usually factors around what beauty is, what is accepted and what is not accepted. In certain communities, in actual fact, because everybody around you is large, if a person is thin, that person will be the one that is stigmatized, because in those communities, beauty is large, and also wealth means large, and astute means large. And in those societies, someone that is smaller would be the one that is stigmatized. And then there was the era of HIV in South Africa, where being thin also carried along the fears and the stigma of having AIDS and being stigmatized out of the community for having AIDS. And people, and especially people living with HIV, had to have like their fat protective image. And you see it in practice. A lot of patients would come, if someone is living with HIV, would be weighing 100 kilograms. If that very patient will now weigh 105 kilograms, they would be admitted for depression because they lost weight. And that weight loss would actually mean I will be now stigmatized for living with AIDS. So you find that an obese person will cross stigmas. Stigma for being obese and stigma for looking sick. And across stigma is actually a very big thing, and it tortures.
Yeah. Dr. Nonjogo, kuba khona environmental discrimination. Ungakusicacisela ngayo ukuthi imaphi esikhathini esiningi ama-patient complaina ngakho?
Patients, they wouldn't actually directly complain about that. But in your assessment and engagement with the patient, there's a subtle inference towards discrimination, sometimes from family members, sometimes from colleagues at the workplace. If umntana esikolo, sometimes the teacher indirectly referred to her as hey, when then so I think we've had a case of because so the question of stigma, discrimination plus social isolation is not only felt at the adult level, but directly, that's right. But the minute you start now delving deeper into the social aspects and cultural aspects of obesity, kudala lo muntu bawafumana ingxaki ekhaya ngokuthi yena akafani nabanye sometimes ngendlela anxiba ngakhona umnye ufuna ukuthi seyizekela nothenga impahla onozinxiba nje nantoni because they said hayi mina ngihleli ndimkhulu kakade so akukho nto ezonenza ndibe right. So anyway ufuna ukuthi abantu they've got some biases that are actually coming from outside and sometimes coming from within and being actually enforced by the environment as on. So that's why in the obesity needs a sort of public health approach plus education and research, so that we deploy evidence-based tools aiming at public health and policies. And abantu ba training policies in the obesity is multifactorial, and everybody should contribute towards make sure that we provide environment conducive for people to come forward and understand obesity as a chronic condition. It's not a fault. It's about you trying to understand. First, she's a person, and then second is a person with a chronic disease, and then you need to understand what are the active drivers of chronic disease, and also how do you assist the person to live a healthier life. Kukhona abantu abakhulu, but not necessarily begula. Now, if for instance you take muscle or wrestler, for instance, on a BMI of more than 30 or 34, you don't say that person obese because that person is packed with muscles, not necessarily fat. So I think we need to begin to educate abantu around obesity as a chronic condition, and also obesity as something that needs to be managed within a context yomuntu as an individual, and see as ukuthi abantu can and live healthier lives with imizimba emikhulu. We should focus abantu more on health than the numbers on the scale. And once you achieve that as a society, abantu benemizimba emikhulu will find it easy to fit your society, be it at home, school, or in the workplace.
Ngokwe-culture yethu dokotela, especially thina abantu abansundu, sinokuthi uma ukhuluphele wondlekile okanye umntwana makamncane esidudla sithi hayi simukubukwana sihle lezi, ungathini ngoba siyakuncoma ukududla thina ngokwe-culture yethu, kepha nina nithi ukugula, ungathini nje namhlanje?
I think I've had a couple of encounters. I think we're dealing now with a cultural context of obesity. I've had a couple of clients whereby when you start to introduce the question of your weight, you request to talk to them about the weight. So you understand? So we've got some stereotypes. Is it sometimes it's a sign of wealth? Sometimes obesity or ubamkhulu is a sign of power, or you need to be visible if you pay a band. So I think we need to manage it sensitively, because in a cultural context, there's stereotypes that have been fed to people by society. So you need to be sensitive. You understand culturally how is she or he has been affected by weight loss, and how is this going to affect her? How is she going to live with the weight within society? And also, if it is B, you need to educate now so that banga means I finish ashamed. I've had patients that after losing about 15 kilograms, for instance, abantu were beginning to ask, hey, they tell me this guys, hey, we've lost some weight now. You know, it just tells you we have actually accepted and also acknowledge and once you lose weight, so more than more lose weight, you're becoming healthier. So that are driving stigma plus bias about people with obesity.
Sibonge kakhulu lapho dokotela. Sis, ke batla hore o re tsemo re batho ba exercise. Exercise is important nje muthu beside obese nje, because we always talk about physical activity. Important physical activity.
Okay. So physical activity is important to improve our overall quality of life. And it can be done by anyone, whether sick, whether healthy, whether young or old. And then it regulates meaning, like it regulates blood pressure. So even if you're trying to manage blood pressure, like you already diagnosed, hypertension, like you already diagnosed, you can use exercise to manage blood pressure so that it can also cleanse your arteries. It can also cleanse, those blood clots that are there to allow sufficient blood in the body. And another thing is it regulates blood sugar. But already who are diagnosed. Exercise at the same time take medication unless advised by the doctor to stop. But we will never tell you to stop taking medication. Medication, and then we'll incorporate exercise so that we can regulate sugar levels. And another thing, improve or manage stress very well. It goes back to being obese. It could be lifestyle habits, and it could be other stresses or factors like maybe work stress, or just maybe financial stress. It could be anything. Says because I'm obesity, as a result you eat a lot, or maybe you respond negatively to medication that you're taking. So it to manage stress very well. Promote those endorphins in your body, and also respond well to other stresses or factors around you. And sometimes as parents, and we worry a lot as our kids age and when things bad happen to them. So it affects us, we neglect ourselves. But with exercise, you are able to think positive act positive, and respond positively to everything that's surrounding you. So it is very important. Hence, I'm saying and emphasizing that you don't need to be sick to exercise.
Okay.
You can use exercise as a preventative measure, and you can use it to manage existing chronic conditions.
Bothata ba rena he re nagana exercise re nagana o shiana. So I can imagine ore motho o lwalang o na le sukiri o na le cancer ke di exercise thing because usually especially he ke lwala ke feel nka re nka nna mpetong, you know, what are those exercises maybe it's once ke dire because rena re nagana o exercise re nagana o shiana mo tseleng.
So one thing I would like to note is that exercise is not supposed to hurt. In order to feel that it's working. It's something that you are supposed to enjoy so that it can be effortless whenever you want to engage in it. And then exercise, you also need to plan. I'm going to exercise today. Alternatively, you can also engage in your household chores, which we call them physical activities, like washing, cooking, maybe cleaning. You know, it could be anything that you do that allows physical exertion. And the type of exercises that you can engage in, which you don't need a gym to go and exercise, it's just that it encourages you to exercise more because there are different equipments within the gym. You know, you can have a variety. But at home as well, you can have a nice space, even in your lounge. You can do things like your lunges, you can do things like your squats, you can also do things like your sit-ups, push-ups that are modified. And be mindful that if you have maybe arthritis, if you have maybe an existing orthopedic injury or illness that you know of, consult with your healthcare professional so that they can advise you in terms of how hard should you exercise, how much should you put into your exercise program, and when, like how often should you exercise so that you don't aggravate those existing problems. So there are a variety of things you can do. Even walking, a simple walk, it's a physical activity, it is exercise. A simple jog in the morning, or maybe instead of like now because of evolution, we're taking escalators, we're taking lifts instead of walking, using the stairs, you know, or maybe the complex is just here, but I'll rather take my car instead of walk to the complex. Rather use those old ways of getting to places because there are a lot of benefits. It enhances your quality of life, and also it can help you stay strong because exercise also strengthens your muscles that you use for daily activities. It doesn't only strengthen the physiological part, but also the physical part. Your ability to walk to a mall, it requires your fitness, your heart to be strong, your lungs to be strong, so that it can pump blood and oxygen effectively to allow you to get to that place without any fatigue. So it is quite dynamic, but I would strongly encourage that whenever you have an opportunity to just, you know, like I'm sitting now, whenever you have an opportunity, you feel like fatigue, you know, this is what you can do.
Just by sitting there. Okay.
Just so you modify every way. It is possible to conduct it everywhere. As I say, you do not need a gym to go and fulfill your exercise program. Anyway, anytime, for as long as you are creative and use everything at your disposal to get strong.
Ekhaya awusenayo idabu lapho asenakho ukubaleka ukuthi awunayo imali yokuya kwa-Virgin Active nayo indlela usisabekeli usibonisile ukuthi ungakwenza uhleli ekhaya. Sisabekeli usayenza leya exercise. Baningi abantu abacomplainayo lana ukuthi ngiyaslima, ngisebenzisa imijovo ngenzani, mara inkinga ila. Senza njani ngomkhaba?
Okay, so enkulu kubalekile ukuthi ama-sport reduction siphume kuwo, because ama-sport reduction wuwo lawa asenza ukuthi sisebenzise izinto ezi-wrong. So you can see a dietitian who can advise you on eating habits that can also combat fat distribution lapha. Instead of taking ama-supplements lawa angakho verified ukuthi uwathathe, at the same time affect health yakho. That's why in the long run you find people that diagnosed with chronic conditions. Lawa they shouldn't have had those chronic conditions, but because of the things that they used, which were not medically proven to use, it as a result they affect umzimba wabo. So sport reduction, I will strongly discourage exercise. It is possible ukuthi ube a lean maybe body, or ube ungabi nomkhaba kakhulu, usebenzise exercise. But I would strongly encourage ukuthi asiphumeni with that mentality yokuthi a flat stomach it means being healthy. Meanwhile, that's not the case. Because if flat stomach layer, yes, it's nice to have it's nice to have a six-pack. It is nice, but it does not imply that you are healthy.
Oh.
Okay, so a person ngingaba njalo ne kube no person obig, and then that person is even more healthier than me who's lean, because I use those things. So spot reduction, it's not ideal. Exercise, improve your heart response, improve your muscles. At the same time, you'll be benefiting your entire body to be, because we want people to be able to help themselves execute daily life activities. So will flat stomach help you to execute daily life activities? What we need is that your core must be strong to allow you to execute daily life activities. Those other things that we see, it will come in the long run, for as long as you also know your fitness ability, that if I want a flat stomach, I need to work hard. I need to push, and at the same time, I need to consult with healthcare professionals that can also help me. Maybe my eating habits are weak, then they can encourage me to eat healthy and also follow the programs, because it goes back to having SMART goals. Losing belly fat is a SMART goal, but it's a goal, but you need to make it aligned with when. It cannot happen within a week or two. You need to align it to your capabilities. Do I exercise, or do I just eat and sleep and expect my stomach to go? And then you also need to have a time frame that, okay, fine, maybe in 3 months I should have at least lost centimeters. You know, that encourages, because centimeters are my waist circumference to measure if you are making progress or not. So spot reduction is not ideal, basically.
As the ideal exercise, the ideal diet. Give being ideal diet bila CDC recommend, because rabona the type of diet tse mo lefatsheng. So give being ideal diet bila.
Just to simplify, because like as you're saying, there are different kind of diets, and governments of the world also have like their own recommendations that this is how the population must eat.
Yeah.
So, and let's remember that population health guidelines are not necessarily therapeutic diets. So when we apply them, this is like for the general health of the population, right? So you remember we come from like the pyramid guys and things like that, but an ideal way of eating would have food items, and I'd like to simplify it. Eat as near to the ground as possible. What comes from the ground as is. So your diet should at least have about 70% of what you eat should be tangibles of what comes from the ground. So if you just think here an onion, picked it from the ground. If you're thinking tomato, from the ground, spinach from the ground, cabbage from the ground, apple from the ground, orange from the ground, lentils ground. So at least 70% of your diet must be what comes out of the ground. Then you know that even if when you're doing your groceries, when you look at your grocery basket or your food purchases, at least 70% of what you acquired must be from the ground. An ideal way also would be that which comes from the ground, actually you planted it, or it was like something that you acquired from your own home, the bigger part of it. But seeing that we are where we are in the cities and all that, when we're going to buy, so 70% of what you buy must be like ground food. So your ground nuts, your legumes, your beans, they are ground food. And at the most, 10% of what you eat should be what is manufactured at the most. If you need to have manufactured food, it should not overgoes 10% of what you consume. So if now, say for instance, you open your fridge and all you find is manufactured food, say for instance, if you open up your grocery cupboard, you're having tea and you're putting some creamer in it, that is a manufactured thing, it's not milk. Okay, so you'd want to have milk as opposed to a creamer. If you're going to have like your breakfast, you would rather maybe have like an oats, it comes from the ground, as opposed to you having a polony, sausage roll, a cheese. They are not ground food. So you want to weigh that maybe out of 7 days of the week, at least 4 or 5 days of the week, your breakfast should come from the ground. So it could be your sorghum mavela, it could be your oats and things like that. And it makes things easy. Or you could have like a banana and an apple and a yogurt. So that pattern of eating is much more preventative of many chronic illnesses. And seeing that in South Africa, people eat a lot of animal food. So say your animal intake should not exactly exceed 20 or 30% of what you eat. So about 20% of what you eat, what you buy, for instance, would be like your animal food. So, but in South Africa, you find that people from the time they wake up, they're on animal food. Because from the time a person wakes up, they will have sausages with bread and some soda or a juice. And if you look at it all that way, all that is actually manufactured food. By lunch, a person again will go for manufactured food because you find that you pop out money, you're going because you've been seeing adverts and you purchase what comes from the food industry, and you come home and it is the same thing. So you find that when we're eating industrialized food, they do a lot of harm to the hypothalamus. And that's why we have a lot of hypothalamic injuries that actually pre-exposes us to multiple metabolic illnesses. Not only do they present hypothalamic injuries, but they present a lot of cellular injuries that actually present a lot of metabolic injuries from metabolic cardiovascular symptoms from the time when we are young. So ideally, even from the time we give birth, the reason we say children must be on their breast milk is because a child should not at birth be exposed to manufactured food. So I would say an ideal way of eating is that at least 70% of what we eat should be coming from what nature provides. And the simplest other way is just to look at it to say, okay, do we have grains? Do we have plants, vegetables, fruits? And then if you say that at least 60-70% of what we have comes from there, then you can say animal food. You look at your milk, your eggs, your chicken, and then you can say what else? If ever you are looking at maybe having some sort of manufactured food, just at the most like that 10%. So this is like maybe on Friday we're not cooking, I will bring a manufactured food, and the rest of the days we were cooking. So it's more or less that way, without trying to box it to have this many number of, you know. So I think the most simplest way is just to look at it, to the ground.
Kuyezwakala kakhulu. Hayi ukuthi sigcina ngayo Dr. Nogaka noma njani. Siyazi ukuthi uma sekuhluleke exercise, kuhluleke ukudla kahle, usuzamile wahamba ngisho namaklinika wabo Dr. eGqeberha kuhlulekile. Then sigcina ngabo akusinjalo dokotela. Sigcina ngabo Dr. Nogaka manje ukuthi abantu abanjani ekufanele manje beze babonane nani or mhlambe aba suitable for bariatric surgery.
As you mentioned that indawo yokugcina yokugqibela, we assess patients. You don't take any patients or all patients. You assess patients. They have to have undergone all these steps that we're talking about. And they have to show a will to do it. So they must be psychologically prepared. They must be ready to undergo this life-changing situation, like physiological changing situation, because now your bariatric surgery, as you in a too many unwanted effects. So it's simple the last resort. We do it, surgeons do it when really your obesity will affect your health. So it's recommended for people who are at least more than a BMI more than 40. I'm not sure medical is approval BMI, but more than 40 or more than 50, it's really, it will affect your daily living. You can't do your normal things like washing all the normal things that a person should be doing. And also it affects your obesity will affect your overall health, like your diabetes becomes uncontrolled and all, and other chronic diseases. So this is really a last resort. With these problems, associated problems, when bariatric surgery is done, they divert food. Okay, they divert food instead of going to your stomach, they'll go straight to your intestines. So the absorption, that food that's supposed to be absorbed will not be absorbed and digested, will go back without the proper absorption. Another way is you make your stomach smaller, meaning they will put a balloon inside your stomach so that even if you eat, you get full within no time, which has its own side effects also. And another way will put a band on the stomach that makes your stomach smaller, which still has its own problems. Like you can have your erosion, meaning whatever is artificial that is put inside you, it can cause erosion in your body and bleeding and more complications. There are things like if you divert food, things like dumping syndrome, like your stomach get to be empty within no time. So it causes lots of other problems like your lightheadedness and the other symptoms associated with it, and certain vitamins that are very important for you and get to be they'll bypass, because in your body, each part of your body is very important. I think when God created us, He was extremely clever. There's something which is absorbed in the stomach. There's something which is absorbed in your stomach outlet, your duodenum, and something which is absorbed in other parts of the intestines. So by doing artificially, we're creating more problems, but having said that, we're saving life and giving you better quality of life. I come across lots of patients who need certain procedures. Now they'll be obese, not too morbid obese. They don't have certain diseases. Obesity also affects wound healing. They affect the wound healing badly. You'll come with a patient, it is obviously breast reduction. But now the question is, the patient is too obese. The wound healing will be poor. That patient will not, will think that it's the surgeon who affected his wound healing. I usually advise people, please go try to lose weight. And I like what biokinetics was saying. I'll give you 2 to 3 months. Try to actively exercise. I don't want a weight loss through not eating properly or taking all these artificial supplements that causes quick weight loss. I want a person who will go and exercise that improves even your immune system, and then by the time you come, your immunity is much better. But I'm a patient, they misinterpret that. You want them to ukwehla quicker and at work. And the major thing is that you must be healthy and reduce chances of complications. Now, any other operations, when you're obese, can easily get a pulmonary embolism in any operation, or fat embolism. And you end up in ICU coming for a simplest procedure ever. So going to the gym, okay, exercising, not going to the gym, exercising is extremely important for all of us. Eating healthy, I won't overemphasize, also is very important. This weight loss of not eating at all, it's also detrimental, because we need nutrients for you to heal, for you to avoid complications of operations. So that's in bariatric surgery, that's where what happens. Unfortunately, after bariatric surgery, you lose weight like in no time. Then you
lose it immediately. Mangphuma nje theatre sengihleda noma
you lose it within few months, 1, 2, 3
not
months.
immediately after surgery.
Not immediately, but in 1, 2, 3 months, you lose weight, you start seeing. But the issue about it, it's like if you were like, a female will identify with this. If you were pregnant, suddenly your baby is out, and your tummy was biggish, and now your tummy is fat. The skin will remain excessive. So people post bariatric surgery, they were bigger with fat underneath, then they lose lots of fat, but they will remain with still unsightly body, the body which is not looking very well, because there's sagging skins or in all those places that you've lost a weight kakhulu. And also some things to emphasize on obesity. We get to be obese differently. Some shed their fat in their abdomen, some in their bums, some in hips. Some will have in breast, and also in your arms they shed weight there. So fat distribution is quite an also interesting topic, and also drugs we eat and artificial things, they can influence your fat distribution. Like your ARVs might have you might have a different fat distribution, like a person who's not on ARVs, and many other over-the-counter things that we take. They affect your fat distribution, and you tend to not be happy with how you look. So the end product of bariatric surgery, you're still going to need now a plastic surgeon to we call it body contouring. To contour your body and then restore quality of life. Because yes, because your bariatric surgery, now it was saving your life. Now your life is saved, stable for about a year. We see that you are fine now. Your quality of life gets to be extremely poor. Sometimes you find that as you are gaining, there is fat receptors even in your breast. It will be exaggerated, and your breast will grow kakhulu. But when you're losing weight, I was weird, so flat and too anxiety. Now we need plastic surgeon to assist in all those things that we're sagging post
Okay.
massive weight loss. We call it massive weight loss. Thanks to James, they're covering other things.
So now geriatric, as James.
Yes, so exactly what he has said with the criteria, that is exactly how we see it. It must be the last resort. You must have gone to the dietitian. You must have been to the biokineticist. We must see that you have had a concerted effort and stuck to your plan. Then you must also have been treated by a multidisciplinary team. So it's not just one provider. Everybody must have assessed you. Are you psychologically ready? Are you mentally ready? Are you physically ready to undergo such a surgery? Because as he explained, it's not an easy surgery. The complications can be hectic. So as he said, we need you to be healthy before you go in. And also it reduces the complications you get from that. We look at also the BMI. We use about 35. And we look at your comorbidities. What else do you have on top of the obesity? We've had some members apply for bariatric surgery, and we could say, haven't been sticking to your plan. Let's give it a good 3 more months, 4 more months to see where you go. We need you to be committed. We need you to stick to the plan that you have been given. Don't off-ramp and decide you're going to do your own things. Stick to the plan that the professionals have given. And you'll find that after 4 months, they canceled the application because after sticking to the plan that their team has given them, they were able to lose the weight through those interventions.
Okay, since you are covering for bariatric, do you also cover for injections like the the Saxenda injections?
So we get the applications, right?
Okay.
And as you know, medical aids always have something called exception management. We do have some members on the injection, but we look at the conditions. We look, what is your weight? What is your level of obesity? How many comorbidities do you have? Are you able to even exercise? That's another thing. Do you have the arthritis that limits your exercise? So how do we now say, no, go to the biokineticist when you're not even able? So we look at things like that. If you have diabetes also, we know that one of the injections under a different name is actually used to treat diabetes when you also have certain aspects of the diabetes. So we also look at those things. Are you able to use a different type of one? If not, then we look at those clinical exceptions and we allow members to be on them. And that's how we review the applications.
No, it's loud and clear. Kuyavakala kakhulu lapho ukuthi i-GEMS mawungabe kuyo i-medical aid, they are willing to assist you in managing your obesity. Sibuyele kuwe Dr. Nogaka. Akusiyo kuphela le surgery. Kukhona ama-liposuction, kukhona o-tummy tuck, kukhona abo-lipolysis. Ngicela ukusithathe nje, especially ku-light 2, ku-liposuction nabo-tummy tuck ukuthi nisuke nenzani-ke lapho?
Interestingly, we, especially the sethu, sipopularizwe nge-cosmesis. Kakhulu. As a result, kwa plastic surgeon, they think of your tummy tuck, your liposuction. So, to be honest, we're doing about 7% of what we're doing is liposuctions, tummy tucks. Having said that, it's quite a big number of people coming to request it. People will want a quote over the phone, over internet. We'll say, no, you need to be assessed by a doctor because there's no one size fits all. in operation. You need to be assessed and see which one do you need. There are people who've got fat distribution on the abdomen, but will qualify more of in liposuction. There are who will qualify more in tummy tuck. For tummy tuck, you need to have excessive tissues, like your skin is excessive, your muscles are, I'll say, torn apart, like they have a gap with a potential, sometimes potential that you can have hernia from your intestines will go through those muscles. So in your tummy tuck, we correct that being torn apart muscles and put them together. And then the excess apron, we can say an apron, we cut it out in a manner that is going to be more good looking after you've done. That's your tummy tuck.
Okay.
And also, it's also good for people with poor skin elasticity. So then you take out the excessive skin, and that's it, you get a flat tummy. But now, on the liposuction side, remember, we're taking off fat on that part. If your skin elasticity is not good, you'll have flatter tummy, but still unsightly flat tummy, which is, as I mentioned, that there's abnormal fat distribution to certain people. Some will be on a tummy, we take that fat out, and that's it. Or on your arms, some will have fat distribution on their breast, like the male part will develop bigger breast. So we liposuck out. So basically, all those things, we call them body contouring. They are not slimming agents. You're not going to lose weight. You are contouring your body to look nicer and have more strength to go to the gym and lose weight. So they're not replacement of weight loss.
Okay.
As much as tummy tuck will take a big chunk of fat, if you weigh it there, you find that at most it's 3 to 5 kgs.
Post-bariatric surgery, can I still fall pregnant?
Yes, there's not, especially post-bariatric surgery, there's no problem at all. But remember, we spoke about nutrients that are not there. So,
how then do I replace the bariatric surgery? Now I have the nutrients problems. How do I replace them?
In your bariatric clinic, from the moment you do the surgery, in fact, prior to the surgery, that's what we call the pre-prep. So as they qualify you for like when we decide as a clinical team that particular patient will go for bariatric surgery, part of the therapy is the nutritional prep for that patient to qualify and to recover. So the dietitian in the bariatric clinic will prepare a clinical nutrition plan to prep the patient for recovery post-op. And then there is now like what is called scheduled maintenance visits. Because remember that the scheduled care for the patient post-bariatric is a lifetime thing. So there will be scheduled visits like the first 12 months post-op, then the next 2 years post-op, and then the lifetime plan. So the dietitian in the bariatric clinic will already have plans in place how to replace certain types of nutrients, how to assess for nutrition deficiencies and nutrition care throughout the program. So most of the nutrients are going to be taken by supplementation, others may be taken by injectables, depending on what really needs to be done. Whether it is things like the B12, which would have like scheduled injectables, and there will be things like your iron and your folate, and then copper will be done much later. So the dietitian in the clinic will actually have a program as to what to do when post-bariatric surgery. But the maintenance thereof is actually a lifetime thing. So obviously, years down the line, the scheduled visits could be reduced to like 2 visits per annum that the patient will come for an overall.
Wow. Dr. Gnugak, kube khona laba abanama beauty surgery. Angazi nabo sebe ama-plastic surgery lapha ngaphakathi noma benza o-lipo la sikwenziwa. What can you say, especially about liposuction, bakutshela ukuthi bayenza i-surgery? What are the dangers about that?
We were taught to not do any procedure that you are not going to manage its complication if they can.
Yeah.
They can be successful with 99 patients. One patient, you get complication, then it's a serious problem. The issue is they will do procedures sometimes that are not. For instance, we plastic surgeons, we will do a liposuction in theater, in a proper theater. That increases the price of liposuction by 3 times.
Okay.
A theater time and that day admission. It increases the price 3 times. But they'll probably do in their rooms. And it's much cheaper. But the question is, if a patient complicates there, in theater, it's a controlled environment. We're able to act when you complicate. There's an anesthetist who's also looking after your cardiovascular system. There's me who's going to be able to resuscitate you in a controlled environment. There is ICU, which is nearby. There is all those things, because the issue is, we know some people are allergic to certain things. You inject the injection that we use when we're about to liposuct. If you get complication, the patient is allergic in that injection, there's a serious problem. So I feel it's more riskier to do it in an uncontrolled environment, also with a person who's not trained to do it.
No, kezwakala dokotela. Azwiki, hona le diet tse ngata, hona le low calorie, low protein or high fat or low fat, hona le fasting. What can you say about those different types of weight loss, slimming, especially involving diet?
Okay. At first, one thing I want to say that slim is not healthy. Slim at no cost is the worst thing you can do to your health. Health is health. Slim is slim. The reason people resort to short-term, quick, fast here, diet there, diet this, is because we're looking for slim. And slim, unfortunately, is influenced by a lot of things that we see. So I just want patients to always separate what is the difference between slim and what is healthy. So if you're looking at whether you need like a high protein diet, low calorie diet, low carb diet, no carb diet, and things like that, patients need to remember, or people need to remember that the way our cells are geared to function, nature sets the cells up for how they should function. So our cells have a certain way of preferring how they should get the energy. So primarily our cells are set up for wanting to use energy from glucose sources or carbohydrate sources. So it's about that we need to choose the right type of carbohydrates. And when we take carbohydrates out of the diet, we are already changing the way the cells must function. metabolically, that in the long run damages the metabolic processes of the cells. So, and that's why if we do the no carb diet, we lose weight quickly and sharply, but what we are losing, it's not the fat that we're losing muscles and hydration. So what we gain is slim, what we lose is health. Okay. So that's one, and that's the flip side of the low carb diet. At some point or another, the brain revolts. So once the brain begins to revolt, you will regain all that weight and twice more, because the brain needs to preserve life. The brain knows what it is geared for. So like that's how you need to understand that. So it can be a no carb diet. There has to be carbs, the right type of carbs. And then you can just do the high protein diet, no carbs also. Because in that, you damage the gut. When the gut is damaged, what the patient gets, the patient gets weight loss, and again, that is not fat loss. It is muscle loss and hydration loss. And the patient will start to present with a lot of constipation. The gut also loses a bigger part of its natural microbiota. In the long run, that patient's gut cannot protect the entire body. And the patient develops a lot of digestive health problems. So that's why sometimes patient gains slim, and then with that they gain a lot of hemorrhoids, piles, chronic constipation, irritation, mood swings, and things like that. And then sometimes patients do the keto diets, which is not supposed to be sustained. So when the keto diet, then the patient puts themselves into a diuretic process. So they put the brains read it as starvation. So yes, the patient at that time becomes slim or lose weight. Again, what you lost, muscles, hydration, and in that you begin to mobilize your fatty acids into the bloodstream to function as sources of energy. And you start to have a lot of ketones, you change the blood pH. In that, you retain a lot of cellular damage. So you find that patients that are following like the high-fat diet, no carbs, what they do is that they insult and they assault the body. Patient sleeps quite quicker, very, very rapid, and then they're dehydrated, they have a lot of electrolyte imbalances, and you'll find a whole lot of fatty acids swimming into the bloodstream. Those are the patients that come with triglycerides that are sky high, cholesterols that are sky high. The patient has gained slim, at that point, the patient has become slim, gained a whole lot of cardiovascular complications. So I don't know what is worth it. So looking slim at all costs is the worst thing you can do to your health. Never mind that with all this kind of diet, you acquire permanent metabolic damage. So in the long run, you find the inability to regulate your metabolic cycles. And that's when patients will say, I've been to diet A, B, C, D, E, I've lost weight here, lost weight there, Eventually they stop losing weight, and then they gain a lot of weight and become obese. Because at that point, the metabolic cycles have learned to shut down, the brain has reached a revolt, and that's when patients develop a lot of other metabolic complications.
Dr. Lungisa, labekhaya ngicela nje ukusithathe usibeke ukuthi uma umuntu ethi ngifuna ukuba ne-successful weight loss management, yiziphi indlela afanele azihambe, noma nje uma ngithi nje ngifuna ukuba ukuluza i-weight, yiliphi uhambo afanele ngiliqale from today?
Firstly, the first thing that you need to do when a patient sees a question enjalo is to engage the patient deeper. What does she expect from a consultation, from a weight loss program? Because at the end of the day, we will start a program, your weight, Tina, what you say up front, we categorically disclose to our patients that we're not in a weight loss program. We're in a business of managing obesity or patients living with obesity as a chronic condition. And we're in the business of making them or assisting them to gain health. Understand? So if they say want to lose weight and gain health, yes, then we accept that we can work with them. But if they're in a process of we just want to lose weight, no, they're not ready to be accepted in our facility. We actually send them back for counseling so that they can be reassessed whether they mean to just lose weight or they just it's a misnomer. But we do a process of assessment. We look for causes of weight loss, and then look for complications and barriers, and then we do what you call goal setting. And then in the goal setting exercise, we want to make sure that we we set realistic goals, looking at weight loss and health gain, and then we set up systems for actually supporting them, including human resource and financial resources. I mean, weight loss program as part of chronic disease management program in obese patients or patients living with obesity can be quite an expensive exercise, especially medical aid. But we know in the long term that they're going to gain health and the quality of life. With patients that are obese, we know that they lose minimum about 15% of their lives. So in other words, they complicate, they die younger, 15 years younger. So that's what we're trying to impress upon them through education and counseling in the process of us engaging with them. So yeah, in terms of patient assessment, at the end of the day, it becomes a multidisciplinary team of dietitians, psychologists, people that are going to assist the patient with going back to phased-in physical activity, because we want them to get injured. Because sometimes if you exercise, you get more complications from exercising, and then the benefit of exercising. If I come to guide, especially if the heart is not ready, or there's some other complications or comorbid conditions like cardiovascular complications of obesity. Sleep apnea, and that needs to be assessed as well. So at the end of the day, it becomes a streamlined and structured process with the patient becoming involved and with realistic goals and maybe some tweaking in the form of expectations. Expectations as Lendele are realistic, they're specific, they're measurable, they're timed, and also it's very important that that assessment or intervention, after the intervention, is the patient going to be able to sustain that program? So that's why we don't chase the numbers. We're chasing the best way the patient that the patient can maintain. Looking at the evidence in terms of science and clinical trials, is it to what sort of percentage body weight must you use and maintain? And we know with some interventions, there was 15%. But the challenge with weight loss, because chronic programs, is sustaining that weight, which is why you need to make sure that you manage that process upfront with the patient and support system, including choosing the tools that you're going to deploy, in the process, so that at the end of the day, the patient can sustain the weight loss. Because once you reach 12 months, then it becomes a problem to actually maintain and sustain the weight loss. And we don't want the patient to do yo-yo type of weight loss, because that has got its own complications as well. So you spend more time in informing, educating, counseling the patient through a multidisciplinary approach, including the patient at their long-term program, because you're looking at sustain for the long haul, not only for short-term, 3 months, 2 months, 6 months. And yeah, that's what we do.
Basis, which is what we do. So thank you very much.
Abigail. exercise.
All right, so I just want to say that see your healthcare professional to encourage you and to give you a scientific-based, individualized exercise program that is suitable for your needs to help you achieve your goal and stay healthy, stay active, and embrace life.
Thank you so much. Dr. Lukaka?
I'll say, when we say, please, we cannot operate or do your liposuction, it's for your own safety. Don't go doctor hopping because I said no, we cannot do. We don't want to intervene on doing something that can wait and you get complications. So, please make sure that you listen carefully to doctor's advices and work with your doctor before all these interventions should be done after you've done your gym, you've done your diet, then we feature in after all those interventions. Thank you.
Asvik, esibathu babuzisa ku high, ukaring ka banting, utswalile. 1 second vela ka banting ukaring kayo.
Okay. Venting will surely make you sleep. You will gain sleep and you will lose your cardiovascular health. In the sense that you will gain with it free fatty acids into the bloodstream, like your cholesterol to your triglycerides, the raise is quite a lot for dehydration. But you will surely be sleep. That's what I can say.
So they need to also, that means to go to the doctor and check their cholesterol levels. Nisivele lapha emakhaya ngathi singathatha ilanga lonke sichaze le ndaba kepha isikhathi sidliwe yinja